to order, and I will start with approval of the minutes. But before I do so, I've been notified that when we use these, we have to hold this down because otherwise it will stop. So hold it continuously. Yes.
Good morning. I have just one substantive correction on page 64, line 9. I believe it should read, currently the levels are 40, 250, the number, and 400 micrograms of lead per square foot. It says the word 2 space 50 for the middle one. So that's the only substantive thing I can.
Terrific, thank you. Anyone else? Okay, I'll entertain a motion to approve the minutes.
So moved.
Second?
Second.
All those in favor?
Aye.
Any opposed? Any abstentions? Okay, so we will then move on to the first business of order, which is notice of adoption to amend Article 11, 71, and 173 regarding lead in paint. This notice was published in the City Record on April 23rd. A public hearing was held on May 23rd, and we have received 4 written comments. So if the team will come up, please.
Hi, everyone. Am I on? No? All right, that's better. Great, hi, I'm Chris DeAndrea. I'm the Assistant Commissioner for the Environmental Disease and Injury Prevention Bureau, and with me is Andrew Fasciano, the Director of the Healthy Homes Program. To get started. So we received comments on our proposed amendments. Written comments were received from 4 organizations: the New York Lawyers for Public Interest, the New York City Coalition to End Lead Poisoning, both of whom testified at our public hearing on May 23rd, the Children's Defense Fund of New York, and the Real Estate Board of New York. With regards to Article 11, Section 03, blood level reporting, comments were in support with additional recommendations. Notification should be coupled with prompt provision of supportive services for our caregivers of the lead-affected child. We currently provide those services. We provide services that are consistent with this recommendation. Currently, we will continue to do so. We also received a comment that we should maintain all appropriate safeguards to protect delicate medical information. We agree, and the Health Code provides in sections 09 and 11 of Article 11 to treat this information confidentially. In addition, the department maintains robust electronic systems compliant with federal regulations for safeguarding such data. With regards to Article 173, Section 01, we received comments in support with one additional recommendation that DOH-MH should expand the definition to include other common personal injuries caused by lead exposure, to include neurological damage, behavioral disorders, and functional deficits. The language included in our proposed change does not limit the definition to the injuries listed and is sufficiently broad to cover these types of injuries that I just mentioned. With regards to labeling requirements in Section 05 of 173, comments were in support with additional recommendations to strengthen and clarify the language further, incorporate pictographic depictions to communicate risk, and use multiple language outreach campaigns to promote meanings behind these depictions. The language and labeling requirements that we use reflect existing guidance provided under federal law. The department will use current enforcement authority to ensure that messaging is appropriate to reach users of these products. regards to Section 21 of 173, comments were in support, with additional recommendations that the health code should include regulatory provisions for the way DOHMH will enforce provisions against distributors. The language included permits enforcement against distributors. DOHMH will use the health code to enforce the embargo on retailers and distributors, as we currently do within New York City. Also, DOHMH should include outreach to online retailers as part of its regulatory planning, and we will raise awareness among as many stakeholders as possible. With regards to Section 01 of 173, we received 3 comments in support, but there was comments that the change is not sufficient and recommended testing and abatement of all surfaces, regardless of the condition of the surface. DOHMH testing and enforcement actions are guided by risk of exposure to lead paint. Intact lead paint on a non-impact or non-friction surface does not pose an exposure risk. One comment in opposition that we received was from the Real Estate Board of New York, which recommended that the Health Department not change the XRF level, the threshold level, until an XRF is approved by HUD to test at such an action level. They're referring to 0.5 milligrams per centimeter squared, and our response is that we are confident in the ability of our equipment to measure lead paint at these levels. We have standardized paint films at a variety of levels to show the instrument's measurements are accurate. And that concludes the comments.
Great, thank you. Any questions for our staff? Yes, Dr. Klitzman.
Thank you. Good morning. I think it's a testament that this is an effective approach, is evidenced by the continued reduction in both the magnitude and severity of children with elevated blood lead levels, and still, you know, the department is very vigilant in making sure that we really eliminate this issue as much as possible. I just had 2 questions for you. The first is, what was your response to the comments submitted by NYCHealth about their alleged lack of enforcement of Local Law 1 for landlords to preemptively inspect and address lead hazards? I realize that that is not a DOH issue, but I also know that DOHMH and HPD work hand in hand in reducing lead paint hazards, and is there any thought or increased collaboration with HPD around that concern?
Sure. So, as a matter of course, every time we issue an order, and when we identify lead-based paint hazards, we have to certify that address to HPD, and they, at that point, do a Local Law 1 audit of that building owner to examine the record to see their compliance under Local Law 1. So there is some Local Law 1 oversight being done, but as part of the mayor's announcement, the Lead-Free NYC, the roadmap, HPD is dedicated to developing a building lead index, where they're going to look for proactive strategies to try to do auditing, Local Law 1 auditing, based on a variety of different approaches, some based on building age, some based on previous history. So we've been working with HPD to develop like the algorithm that they should use and helping with the evaluation. I think they have some rulemaking to do before they're able to do that, but that's one of their commitments under Lead-Free NYC, is to do more proactive audits of building owners under Local Law 1.
Fantastic, thanks for adding that. And my last question is that you're proposing very stringent dust lead clearance levels after addressing lead paint hazards, and I would just like to request at some point in the future you could report back to us on the ability of landlords to achieve those clearance levels.
Definitely.
Thank you.
Great, Ms. Redlin?
Hi, thank you for the update on your response to the comments. I'm just wondering, a couple of the responses and requests were about making sure that the public is aware of some of these new risk labels that are going to be added to, you know, dishes and other products that could have lead in them. And the comments, I think, were making sure that the outreach was broad enough to reach the populations that, you know, could be using these equipments, and making sure that they understand what the signage means, what the risk labels mean. I'm just wondering if you, in response to the comments, were planning to expand the outreach, or you already had considered the outreach? I mean, it was a little unclear in your responses here. Just if you could explain a little bit more about what the outreach would be, to make sure that people understand and it's communicated in languages or
Right, so I
symbols.
would say first off, we're reflecting the federal language, so the law already exists. So we're just codifying it, and people, retailers, distributors are already held to this. As far as product awareness in general, we do have a campaign that currently has targeted South Asian communities with products that have been contaminated. Our outreach has been typically in concert with our enforcement actions, where we find products. Then we'll do additional outreach in those neighborhoods, also requiring businesses to post warning signs where we find products for sale in multiple languages that are used in the communities that are affected. That's been where we have been with this.
I see. Okay, thank you.
Any other questions? Okay, so I think we're ready to call the question on this, and I will entertain a motion to vote on adopting the amendments to Article 11, 71, and 173. Second? Okay, all in favor?
Aye.
Any opposed? Any abstentions? Okay, the measure passes. We will go on then to the next presentation, which is on the notice of adoption to amend 207.05 of Article 207, regarding birth records. And this notice was published in the City Record on the 23rd of April. A public hearing was held on the 28th. One written comment was received, and no one testified at the hearing. Introduce yourself, please.
Great, thank you. Hi, my name is Gretchen Van Wy. I'm the Assistant Commissioner for the Bureau of Vital Statistics and the Registrar. So the notice of intention that we brought to the board in April, as mentioned, was published in the City Record on April 23rd. We had a public hearing on May 28th. Nobody testified at the hearing. However, we did have one written comment in support. So no changes are being made to the amendment, and we ask the board for approval of the change as is.
Any questions for Gretchen? Okay, hearing no questions, I'll entertain a motion. Second, okay, all in favor?
Aye.
Any opposed? Any abstentions? All right, thank you very much. The next item on the agenda is a proposed resolution to amend Article 11 and Article 13 of the New York City Health Code regarding various diseases and conditions, and I'll ask the program to come up and present.
Great, thank you. Thank you very much.
So I'm Dimitri Daskalakis, the Deputy Commissioner for Disease Control. Nice to see you all again. Today, I'm going to talk about some ideas for our Health Code Articles 11 and 13. So just to remind you, Article 11 regulates disease surveillance and control activities, including what diseases must be reported to the health department. Article 13 regulates the manner in which lab tests must be performed and reported to the health department. So we have several proposals regarding both these articles. The first is amend Articles 11 and 13 to require laboratories to report all test results for tuberculosis infection. Add a new section to Article 11 to require healthcare providers to test pregnant persons for syphilis at week 28 of pregnancy and no later than week 32 of pregnancy, and to document that test result in their medical record with a treatment plan. The third is to amend Article 11 to provide the health department with greater discretion to end exclusion of people infected with enteric pathogens. And the last is to amend Article 13 to no longer require laboratories to perform culture testing on all specimens found to be positive for one specific bacterium, Campylobacter, by culture independent diagnostic test, or CIDT. So I'll start with the TB infection reporting. So as you all know, TB is a disease caused by the bacteria Mycobacterium tuberculosis. It is spread person to person through air. Individuals with a positive immunological test for TB infection but do not have symptoms or other test results consistent with active TB disease are diagnosed with latent TB infection, or LTBI. Persons with LTBI are asymptomatic and they cannot transmit the infection to others, but the infection can reactivate, causing them to become sick and ultimately also to be contagious. LTBI is a major target of TB elimination plans since it's the reservoir that can lead to active disease and ultimately to transmission of tuberculosis. So this is a schematic that our Bureau of Tuberculosis likes to show a lot to tell a little bit of the story of latent tuberculosis and active TB disease. So not surprisingly, I'm going to say active TB disease is the tip of the iceberg, and that below the water is a lot of latent tuberculosis infection. One of the major issues in New York City, which I will share in a moment regarding tuberculosis, is that we do not know the size of that iceberg. Like, it's a lot. We know that there's a lot of latent TB infection, but we only have guesses as to how much in New York City. So the World Health Organization estimates that about 1.7 billion people, that's 23% of the world's population, have LTBI, and that's according to a 2017 report. We also know that it is difficult to get an accurate estimate of the prevalence of LTBI in New York City, and our estimates are based on modeling. So I'll show you a little bit of the range of how many TB, latent tuberculosis infected individuals we think we have in New York. So using national estimates through NHANES, combined with New York City population data, that model says we have about 700,000 people in New York City with latent tuberculosis infection. Our own modeling, using data from our health department chest or TB clinics, suggests there could be as many as 1.8 million people in New York City with latent tuberculosis infection. That's a really broad range and really is problematic from the perspective of deciding what our strategies are to deal with LTBI. We also know that whatever the number is, however big, both of those are fairly large numbers, that about 10% of them with LTBI will develop TB disease at some point in their life. So immunological testing for TB infection happens in a couple of ways, by tuberculin skin testing, or TST, or newer interferon gamma release assays, or IGRA, blood-based tests. IGRA tests are generally preferred because they're more accurate, particularly for individuals who have been vaccinated with the BCG vaccine in high prevalence countries. Vaccination with BCG may give false positive TSTs, but because the BCG antigen is not in the IGRA test, you do not get false positives on the IGRA for individuals who've been vaccinated. Treating LTBI is the only way to significantly reduce the risk of developing active disease, and is really a vital component of TB prevention efforts, both the ones that we're concocting here in New York City and also the strategies that have been expressed by the CDC. We also know there are a couple of other more important issues around LTBI, which is that LTBI treatment is less toxic and less expensive than treating active tuberculosis, and we have a lot of new short course treatment regimens for LTBI that have reduced treatment times and toxicity. So we're now down to regimens that can treat latent tuberculosis infection in 3 to 4 months, as opposed to the 9 months plus of the past. Currently, our health code requires providers and laboratories to report test results and other information attendant to people with active tuberculosis disease and for persons potentially exposed to people with active tuberculosis disease. Also, we are supposed to get reports of positive tests and related information for children under 5 years of age. So our proposal is to require laboratories to report all TB infection test results. That means negative and positive lab-based testing. That requires labs to report all of the results, including the negative and the intermediate results. This will be really important in our strategy to address tuberculosis and latent tuberculosis infection, because it will give us a better understanding of the prevalence of TB infection, so we can better help direct our public health resources to LTBI to prevent active disease. And also it will give us an idea of where people are using this better testing to help inform provider outreach, laboratory diagnostic capacity, and then ultimately our strategy to eliminate tuberculosis in New York City. I'll move on to the next, which is syphilis screening in pregnancy. So just a quick review. Syphilis is a sexually transmitted infection caused by the bacterium Treponema pallidum. Untreated syphilis during pregnancy is devastating, and it can result in devastating outcomes, including stillbirth. Infants with congenital syphilis can manifest many abnormalities of the central nervous system, liver and spleen, bones and joints, teeth, eyes, and skin. Congenital syphilis is a significant health risk and is something that we need to address more aggressively in the city. It can be prevented by timely identification and treatment of maternal syphilis. The problem is that symptoms of maternal syphilis during pregnancy are transient and may not be apparent, so routine, non-symptom or risk-based serologic screening during pregnancy is critical. Syphilis screening is actually currently mandated by New York State at the first prenatal care examination and at delivery. And unfortunately, New York City syphilis rates greatly exceed national rates. The rate per 100,000 population for syphilis all stages was 95.33 in New York City versus 31.4 nationally in 2017. We also are seeing trends in primary, secondary, and early latent syphilis among New York City women, increasing by 44% from 219 to 315 cases from 2017 to 2018. This is preliminary data. Congenital syphilis cases in New York have also increased, though numerically small, by 186% between 2017 and 2018. That's 7 cases increasing to 20, including 1 syphilitic stillbirth at 31 weeks. Again, this is also preliminary data. 20 is the largest annual number of congenital syphilis cases reported in New York City in over 10 years. In New York City, there's an increase in the proportion of congenital syphilis cases that are related to maternal syphilis that are actually acquired after an initial negative prenatal screening test. This accounts for at least 11 of the congenital syphilis cases in 2018. At least 6 of these cases could have been averted by screening and treatment if we had such testing at 28 weeks of pregnancy. So this graph really shows some of that story. So I'll have you focus on the blue section of these stacked bar graphs. These represent maternal syphilis that was acquired during pregnancy. The green part represents individuals with late or unknown prenatal care, and the orange bar includes other causes, including being diagnosed too late and not enough time to treat before the adverse outcome. So you can see from 2018 that a lion's share of these cases potentially could have been addressed by another not symptom or risk-based screen for syphilis later in pregnancy. So it's really important, these syphilis test results, because we're able to sort of focus some significant effort in case investigation. Test results positive for syphilis are required to be reported to the health department, and it enables our case investigation and public health interventions. So it lets us identify individuals in the registry, contact providers to gather current testing, treatment, and clinical data, really find patients and interview them to identify other partners to prevent reinfection potentially, and then ultimately we get to case manage them and monitor them to make sure that they get through pregnancy with adequate treatment and that they've had adequate response to their treatment for syphilis. So our proposal, based on our data, is to require syphilis screening in the 3rd trimester. So this means mandating syphilis screening to occur at 28 weeks of pregnancy and no later than 32 weeks of pregnancy. So providing some range for the provider based on their visit schedule with the patient to identify pregnant people who become infected subsequent to that mandated New York State initial screening. This will enable timely treatment of syphilis in the pregnant person to prevent adverse health outcomes that are related to this, both to the individual who's pregnant as well as to the fetus or infant. And also, it syncs really well with other visits. So other prenatal screening tests are routinely performed at 28 weeks, so, and those involve a needle. So it's not a lot to ask for one more test to be obtained from that blood draw. It requires also another important step, which is to require providers to document the test results and treatment plan in the medical record to help assure appropriate follow-up care. So not only has the test been done, it's been seen and it's been addressed. Several other states require 3rd trimester syphilis testing of all pregnant persons, so this is just, I think, a good idea based on the data that we're seeing in New York City and the increase in cases, specifically that blue zone in the bar that we talked about, many of which could have been prevented by this additional testing. Moving on to enteric pathogens. This is a proposal around exclusion of persons with enteric pathogens. And to remind you, enterics are microbes that affect the intestine and typically enter the body through the mouth. People who are infected or carrying enteric pathogens can shed the organism in their stool and transmit the infection to others if they have poor hand hygiene practices. The current health code requires exclusion of these individuals from certain settings who have the following enteric infections transmitted through the fecal-oral route: Campylobacter, cholera, certain strains of E. coli, O157H7 and other Shiga-toxin-producing E. coli, salmonellosis, shigellosis, yersiniosis, anabiasis, cryptosporiasis, and giardiasis. The current exclusion requirements are that individuals infected with or carrying these pathogens must be excluded from settings where there is an elevated risk of disease transmission. So that includes food handlers or healthcare workers. They must be excluded from their place of work. Staff and attendees of schools, childcare programs, camps, and other facilities attended by children under 5 years of age must be excluded from those facilities. And in the current exclusion, that can only end when the excluded person no longer has symptoms and the department has received 2 or 3, depending on the pathogen, successive negative stool specimens demonstrating that transmission is no longer likely and that the excluded person's illness is no longer a public health concern. Exclusions can last from days to months. We have seen an increase in frequency of exclusion. The number of people requiring exclusions has increased significantly in recent years. In 2018, there were 187 exclusions ranging in duration from 1 to 135 days, with a mean length of 22 days, as compared to 69 exclusions in 2015. So this increase is at least partially due to the fact that we have improved surveillance practices and the use of culture-independent diagnostic tests, a testing method that is a lot more sensitive than other types of traditional tests like culture, and lead to more positive test results in general. Stool samples can be positive for CIDT, but culture negative. That indicates that although the organism's DNA is detectable in stool, it may not be alive and capable of being transmitted. Currently, individuals must be excluded based on the positive CIDT while awaiting follow-up culture results. Some individuals shed the organism in their stool for many weeks or months after symptoms have ended, and data suggests that the risk of transmission in such cases is very low. So the proposal is to allow for more discretion in ending exclusion, allowing us to take into account the platform for testing as well as the individual characteristics of the bacterium that we're worrying about from the perspective of exclusion. So the health department will consider the circumstances of the individual case, including the type of infection, so which bug, the type of test used to detect the pathogen, presence or absence of symptoms, the individual's treatment with antimicrobial drugs, the individual's job responsibilities, and the likelihood of infectiousness based on the length of time since symptom onset. So this allows us to maintain discretion to exclude people until consecutive negative test results are received if, in the view of the health department experts, there remains a public health threat. So many jurisdictions, including New York State, are less strict than New York City without any measured increase in disease transmission. Moving on to our last proposal, Campylobacter testing. So, as review, Campylobacter is an enteric bacteria that can be transmitted to people through contaminated food and liquid or contact with certain animal feces. Campylobacter causes diarrhea, fever and abdominal cramps, and in rare cases, more serious illness. Compared to other enteric pathogens, Campylobacter is found relatively frequently. In fact, in 2018, we had 2,500 reported Campylobacter cases in New York City. CIDT, that same culture-independent diagnostic testing, is more sensitive for Campylobacter, and that results in positive test results that are later determined to be culture negative, meaning, again, there's no evidence of living organism that can cause disease, just DNA of an organism that had been there before that's likely cleared. The current Campylobacter testing requirement is that in January 2017, we amended the health code to require culture tests on the following enteric pathogens when detected in CIDT. So in other words, if found using a DNA-based mechanism to identify the organism, there was reflex culture. Campylobacter was on that list, including Listeria, Salmonella, Shigella, Vibrio, Yersinia, and again, the Shiga toxin producing E. coli. Laboratories had to report the results of the culture and submit any resulting isolates to the health department. The health department proposed the amendment to enable it to obtain information about the pathogens not available from CIDT, so specifically drug susceptibility against antimicrobial agents, and potentially work to use sort of molecular epidemiology to identify clusters. And that ultimately was thought to be important in assisting outbreak detection and response. So we are proposing to no longer require culture testing on all specimens positive for Campylobacter. No longer requiring laboratories to perform testing on all those specimens is actually important for a couple of reasons. So we have a high number of Campylobacter reports, and the health department generally investigates only clusters as opposed to isolated cases, and does not make use of most of the isolates received from laboratories. So there's a high burden of work that's happening to laboratories and reporting, and ultimately that data is only used when we identify clusters. We would still be able to identify those clusters using the CIDT data alone. Other enteric pathogens have more significant public health consequences, and so we're not interested in backing off from getting the culture data on those, because they're important to have that information and the other data that we need to do outbreak response. They also tend to be more likely to be included as part of local and multi-state disease outbreaks. Additionally, we have great relationships with the providers and the laboratories, and especially for Campylobacter, if we see a cluster, we're actually able to request this specifically. So rather than getting a flood of culture data that ends up being burdensome both to the lab and then ultimately not used in an outbreak response by the Department of Health, we can focus our request to only get the Campylobacter data that we need and request culture when necessary. So ultimately, again, this approach fine-tunes the initial change to the health code and better balances laboratory burden and ultimately what our public health need is. Thank you.
Great, thank you, Dr. Vasilakis. And questions? There was a lot in there, I'm sure. A lot of
Sorry.
questions. Where shall we begin? Ms. Redlener.
Yes, I want to second that comment that there was a lot of information to absorb. Maybe it makes sense for us to go
Sure.
point by point.
Sounds
and
great.
start with the TB reporting.
Sure.
And ask questions about that, and then go on. And I have a number of questions about the TB reporting. So I just want to understand the current situation and then the proposed you know, recommendations a little
Sure.
more. Right now, physicians will test for TB under what circumstances?
I wish I could tell you more about that. We don't have.
What is
Yeah.
your,
So-
what are the tests that you get now and where?
Absolutely. So there are a couple of different categories of tests that people can do for tuberculosis. And so first there's immunological testing, which is not looking for the organism itself, but rather immunologic evidence that someone has been exposed or is latently infected with the bacterium. So it's not a culture, it's not a PCR test to detect the genetic material of tuberculosis, but it's a test that looks at people's immunologic response. There's one that we've been using for decades, which is the TST. You may also think of it as the PPD. So it's the same thing. So the idea is that there's a skin test. There's antigen injected in someone's skin, and if they have presence or have been exposed to tuberculosis or have latent tuberculosis infection, that test becomes positive because it swells to a certain size, and based on who they are, where they're from, what their job is, it is perceived as negative or positive. The other testing, which is much better, is the interferon gamma release assay. So interferon gamma is a cytokine that's released by certain cells when they are activated in an immune response. And so rather than looking at a skin test, there's a laboratory test that takes someone's white blood cells and exposes them to tuberculosis antigens. If they release interferon to a certain level, that test is then perceived as a positive proof of immunological evidence that that person has had tuberculosis in their system before. One of the perks of the interferon gamma release assay is that you draw the blood and you get the result. The TST or the PPD, you have to plant the PPD, and then someone has to come back to get that PPD read. And if they happen to be from a high burden country where they have been exposed to the BCG vaccine, that PPD may very well, or TST may very well be positive. The interferon gamma test actually does not include the BCG antigen in its repertoire of antigens to which the white cells are exposed, so there are no false positives because of prior exposure to the vaccine. That's one vein of tests. The other vein is in active disease. That's when we get a sputum result or a culture to identify individuals who have tuberculosis. There are smears done to look for the organism under the microscope. Culture grows, but it grows slowly, so there are also culture-independent diagnostic techniques or PCR tests that can also identify tuberculosis. So that's the full range of testing. We hear about, through lab reporting, the results of individuals with active tuberculosis, and some of the testing that comes from individuals who we know have had an exposure. The only individuals that we get data from the perspective of these immunological tests right now are kids who are 5 or younger.
So if I can just add to that, in terms, another aspect of your question, moving providers from doing the TSTs to blood-based is actually more patient-friendly because they don't have to come back to have the TST read. It reduces the likelihood of false positives if they've had a BCG in the past, and it's just more time-efficient, cost-effective, and better quality of care.
So is that part of this regulation to make recommendations on the preferred testing?
So we have a lot in store for New York City for this. So we are really focusing our effort on latent tuberculosis infection in a way different than the past. In our plans, we will be going out to do provider detailing, specifically to teach providers in high TB burden neighborhoods about the need for appropriate testing. And the IGRA, the interferon gamma release assay, will be the main test that we're requesting that they use. So I think that there is, our agenda is to increase IGRA testing in New York City because we think it's a better test. So it is part of the reason that we're asking for this proposal.
Any other questions, Ms. Redler?
How about tuberculosis?
Let me just,
Is
Have her
related to-
finish
is
it.
related to her question.
I actually have a number of questions, but I noticed in the, so tell me if I'm asking too many, but I noticed in the summary that we received, there are currently 569 individuals that have active TB that we know about, that That's correct. But we don't know anything about latent TB.
So we only know through mathematical models based on the NHANES study and then sort of models that we've done based on our own information from the TB clinic. So, and the range is huge. I think we said, 700,000 to something over almost like 1.8 million or 1.3 million. So the range is it's hard for us to sort of figure out where to sort of target resources because we really don't know. And we can't even sort of geographically say where LTBI is.
So let me go to Dr. Kara for a minute.
Can you clarify the interferon lab blood test is, one of them is the quantiferon?
Yeah, so it's the same as quantiferon is one of the brand names for that testing.
And if the patient in the community get positive quantiferon and normal chest x-ray, no symptoms, what will be the advice to the primary care physician?
Right, so I think our goal is to treat everyone who has LTBI infection. And so the idea would be that if someone has a positive test, a quantiferon or a IGRA test, they're the same thing, we would advise that individual be screened for active tuberculosis. Chest x-ray is a great next step. And if that's negative, to consider, we would advise doing treatment for latent tuberculosis infection, especially since it's become easier and faster with less toxic drugs. So now the stakes are a lot lower. It's not months and months of INH. We have other agents and they're way more convenient. And we're going to be teaching clinicians through our detailing campaign about what those are.
Thank you.
Thank you.
Yes, Pam.
Just an adjunct to Susan's question Karen's question over there. Can you sort of give us a picture, sort of set the stage for the sort of backdrop of the number of people with TB now? I mean, I was running Bellevue in the early 70s, 80s, when this board, 90s, so, when this board voted to sequester patients who resisted directly observed therapy. And I know what the number was then, but can you give us some more? I mean, is it lower today than it was, say, 10 years ago, 5 years ago, higher?
Yeah, no, that's a great, so thank you for your work in the 80s because you helped control the tuberculosis, the tuberculosis in the 90s, because I think we went from a lofty height of really, TB being a major problem in New York City to one where we have, fair control, except that we're at a plateau. And so about 400 or 500 cases, 600 max is what we're seeing, but we're sort of living at this sort of flat line where we're not really going lower. And really, according to many of the tuberculosis sort of bodies and experts in the world, addressing LTBI is a really important step in trying to bend that curve even further to try to get to better control. Now, of course, New York City will always have folks coming into the country who may have had prior exposures, and so if they're seeking health care, that sort of moment of a check for latent tuberculosis infection could really help us reduce reactivation. So we are in a much, much better place by orders of magnitude. We're happy to share our surveillance report so you can see the trend over time, but it is really a good trend, but a little bit of a stall in the last few years, not because of work to sort of address individuals with tuberculosis and do directly observed therapy. All that stuff is going great in the city. We think the next step is really the next step is to identify LTBI more aggressively and to deal with it more.
Any other questions on TB before we move on? Okay, I'll take Dr. Katz and then Dr. Foreman.
Two related questions. The first is, if I understand it right, we would be asking that labs send the results positive or negative. Mm-hmm. In some ways, that's a departure from most public health reporting, right? Generally, we ask people to report instances of disease. Are there other examples where we currently are asking people to report the absence of disease?
Hepatitis C. So we're getting hepatitis C negative PCRs as well as positive to be able to sort of create a denominator. So this is a very similar, this is a very sort of epidemiologic ask, which is to get a better sense of burden of disease because we don't really know. And I think the absolute number of positive would be helpful, but the denominator of total testing would also be helpful because one of our agendas is to increase that testing.
I don't disagree. I would just note, I always feel that public health reporting is some balance between the need for society to protect itself from disease and privacy. Epidemiologic uses are weaker in my mind as a justification, because there are, I mean, in a sense, we'd be approving forevermore, or at least until we change it. Well, probably the question could be answered by a sampling in a period of time. But I do support and agree that the next level of TB control is going to require this. The other question, which maybe is more of a suggestion, is we'll need to go forward if we're detailing to clinicians, would we be treating patients, especially older patients with positive gamma interferons, for their benefit or for everybody else's benefit? In general, it's thought that if you've gone a very long time from exposure, the chance that you're going to reactivate is pretty small. So what the message is, right, to clinicians and to patients for fairness, right, I mean, in general, as you know, as a primary care doctor, we don't generally do gamma interferon if there's no indication. Even though we are aware that some proportion of our patients would be positive were we to do it. That's been based on two things. One is the sense that the chance that the person will reactivate is low. And then the other issue, which is what's changing, is, and the medicines are toxic. Right, so those two things together, and I agree, the new regimen's way less toxic. But then we still have to deal with the first half of the equation, right? As to, you know, what exactly would we be recommending and why, for their benefit, for society's benefit, and exactly what is the risks are very small with the new regimens, but they're not zero. I mean, so we'd be subjecting people to medicines that still have toxicity and cost and inconvenience, for what is likely to be, if it's a long time ago exposure, very little benefit for them. So the critical issue, I mean, you can't do anything about any of those facts. The critical issue is how that gets detailed, it's a complex message, and what actually goes out is what matters.
Great, and I think we're currently working on what that detailing message is going to be. We're not actually releasing it for probably another year, and that's exactly the conversation that we're having internally, which is, so what is our exact message about treatment? What is our recommendation for certain populations? We're not going to be detailing get a immunologic test or an IGRA for everyone in your practice, but rather really focus that IGRA testing on individuals who are potentially at risk. So that pretest probability for reactivation is going to matter in the equation. So we agree with you. And so that's something that we're internally working on to make sure that we're clear. We're trying to make sure that we're well within what the guidance is nationally as well as internationally, so we're not over or under treating.
Great, thank you. Dr. Foreman?
Thank you. I have actually a sort of a follow-up question. One is, we used to do routine screening of all kids in New York City for TB. We used to use the time test and then the PPD. So one of my questions was, as the situation changes, are you considering, not just for kids but for adults, some recommendations about routine screening to really get a better handle on the size of the population of people who have LTBI? And then the second question related to Dr. Katz's, which is, when it's not so hard for labs to report blood test results to you, just routine, are the negative results de-identified? You really only need the IDs of the positive. So if you get a ton of de-identified data on negatives, it helps you with the denominator, and it hasn't compromised anybody's confidentiality.
So the first question is, I think, again, we're going to focus really on guidance in terms of targeted testing. I don't think that our plan is to do a blanket strategy. If we have more questions about that, I can call up someone from TB to discuss more, but I think that we're going to sort of keep it to very focused on populations who are at highest risk. And the second question is that our current intention is, the way that the lab reporting works, we will be getting identified data. So for both negative and positives.
And on that, I just want to be clear that we have very strict requirements in terms of preserving confidentiality, and I think one of the benefits to having it identified is that over time, we can get a better sense of who are those people who then develop active disease, and we wouldn't be able to do that without having it be identified. For the positives, subsequent positives. Because you can have, right, so we want to be able to understand, are there potential treatment failures, et cetera.
And from the, again, just restating that from the perspective of our security, again, like having data, as sensitive as HIV with some negative and positive results, like we're sort of built to handle that, and also our use for it, at least in phase 1, is purely epidemiologic, but as we get deeper into what we're learning about LTBI, we could go deeper into case management. And so having that data identified ultimately will be important for us. I think the intention is to really evolve our response to LTBI, and sort of having that at baseline with the option of increasing our response is useful.
So any more questions on TB before we move to syphilis?
I have one quick question.
Okay.
I think that as you, as we share this information for public comment, and also listening to the board, I think the messaging and the testing recommendations, the screening recommendations, will be an important element for us to hear about as we think about, approving the regulation change, whether, what the targets are and how elaborate this would be.
I'm sorry, may I just add? Yes, one thing. I guess one thing I have questions about still is a little bit more information about the relative non-toxicity of the new regimes of drugs. I'm sure that the doctors in the room probably have read and know, but as a layperson, I don't. And having watched someone have a course of treatment for a positive skin test with really unpleasant outcomes, I'm curious to hear just a little bit more, even anecdotal information about.
We're able to present.
For the next report.
Yep. I think that's a great, we can have that be both the treatment, the LTBI screening recommendations, as well as a review of what the newer agents are and what their safety profile is like, is, I think, a great conversation for a subsequent meeting.
Okay, let's move on to syphilis. Questions on syphilis? I went first to Doug. I'll go to Dr. Foreman now.
I have a very quick one.
Sure.
I was struck by the increasing number of cases of congenital syphilis and wondered if you had any idea why.
It's actually interesting. There's some CDC published data in the MMWR and other parts of the country that link the increase in syphilis and congenital syphilis to the increase in opioid use. That's not what's happening in New York City. That seems so far to be unlinked. So I think we don't have a great answer as to what exactly the dynamic is. I think we're seeing I think potentially some fluidity in sexual activity with who folks are having sex with. So men who have sex with men who may be infected with syphilis, more likely to have sex with women is one thought. Also seeing the general increase that we're having in women, again, it seems as if it's complex but not related to, at least based on what the MMWR said about the country, not related to the upswing in opioids. Pretty interesting. So again, as always, New York City is a unicorn with significantly different interactions than the rest of the country.
Dr. Richardson?
Thank you. So I was interested in the recommendation that required documentation of the testing in the healthcare record and the treatment plan. Are there other examples of such a requirement, and do you have any strategies to attempt to monitor adherence to this requirement?
So this actually was modeled a bit after the New York State HIV quality programs requirement for all syphilis tests for people living with HIV to also include documentation of communication of that test result as well as a treatment plan in the record. So it was very much sort of based on that It's not a recommendation, but it was part of the quality measure for New York State. So it's really modeled after that. So I think ultimately for individuals that get lab reporting, for us, it will allow us to better track the trajectory of treatment, and in the situations where we have someone who does have congenital syphilis or who we fail, will give us a better sense of where the lacuna is in the treatment plan. So it's based on a New York State model. And ultimately, the goal is when we do investigate these cases, these are sentinel events for us. So any congenital syphilis case or a pregnant woman with syphilis is one that gets to the top of our list for priority. And so we will be in that electronic or written medical record to pursue sort of what next steps are.
So is the requirement only to document positive results or to document all testing?
So the technical recommendation or the technical requirement is to document the positive test result with a treatment plan.
Dr. Katz?
So just staying on that, I mean, the issue always is, as a physician, what kind of physician would I be if I didn't have a treatment plan for a pregnant woman with a positive syphilis serology? And now you're saying that I'm so irresponsible that you want to make sure that I've clicked the box, because what will happen is that will mean that the electronic health record has to have a new box for me to click to say that yes, I've treated my patient, and I don't know that there's data that shows that when you add the click in the box, a lot more people get treated or not. It definitely causes unrest among physicians who feel that their lives have been turned into umpteen clicks and nobody trusts us to actually take care of our patients or to look at a situation that is really serious. So I don't know exactly what the answer is. I do very much agree with the additional text. I have no issue with that. I would say from Health and Hospitals data, at least some of the congenital syphilis cases that we see are people who are initiating their prenatal care at the time of delivery. And that is not an unusual in New York phenomenon, whether it's someone coming from a foreign country who hasn't lived previously in New York, or just somebody who has avoided care. That in our system is the number one way that you get a congenital syphilis. But I would like at the next stage to be thinking, is that documentation of treatment plan. I mean, if you could convince me that that's going to lead to a lot more people being appropriately treated, then of course I would support it. But otherwise, I would at least be wary of it.
So we can also break it out, but in this graph that I put back up again, that green area represents folks who are later unknown prenatal care. So though I think in H&H it may be true, obviously you know what's going on there. So it looks like that's not the main driver of our congenital syphilis. So we have a lot of individuals who get it acquired late, which speaks really clearly to that 28-week addition, or it makes a lot of sense to do that second test. But then also that golden or orange bar, some of that orange bar represents individuals who are diagnosed with syphilis, expectant persons, who then don't get treated. And so some percent of that bar would also be addressed by sort of prompting the fact that a positive test result reflexively needs to have some kind of documentation of treatment. Now that documentation could be a simple penicillin order. It may not be an attestation that says like, I have seen the syphilis test and done it. I think we would look at that and say, positive syphilis test, penicillin order, check. So that's sort of, I think, the level that we would need, not sort of some formal statement, I have seen and reviewed the RPR and have decided that 2.4 million units of penicillin must be administered. That's not what we're looking for. Just some kind of like action with response.
Any more questions on syphilis before we move to enteric pathogens? All right, let's move on to enteric pathogens.
Let's go.
If there are no questions on enteric pathogens, we'll go to Campylobacter.
Which is just another enteric pathogen.
Yes. Any other questions on any aspect of the presentation? Hearing no questions, I will entertain a motion for publication. Second, all in favor?
Aye.
Any opposed? Any abstentions? Okay, so it's moved for publication. So now we will change gears and we are going to do an update, a presentation on an update where the department is in terms of the response to the measles outbreak. And again, Dr. Daskalakis.
In case you haven't gotten bored of me yet. Okay. So thank you again for the opportunity to present a brief update on the measles outbreak in New York City. So I will start with a brief review of the current epidemiology of the outbreak. As of June 10th, there were 588 confirmed cases of measles in New York City. That includes 48 hospitalizations and 17 persons to date who have been admitted to the intensive care unit. In terms of distribution by age, 91 have been under 1 year of age, and I'll footnote this and tell you that 97% of them were unvaccinated. 252 were 1 to 4 years of age, that's 43% of the outbreak, 87% of those were unvaccinated. 125 children 5 to 17 years of age, and about 91.2% of them were unvaccinated. I will also just leave and say 120 adults were diagnosed with measles, and most of them have a unknown vaccination status because we don't have their record in the CIR. So the vast majority of individuals who are being diagnosed with measles in New York City have been unvaccinated. I've not included the undervaccinated, just the unvaccinated. So that will give you a sense of how important MMR has been in the story. Almost all of the cases reside in Williamsburg, that's 74% of them. 17% reside in Borough Park, and most are members of the Orthodox Jewish community. So we wanted to show you a epi curve showing the direction in which we're going. This is an epi curve based on month. So you can see that in broad strokes, we are starting to see that we are on, as we like to say, the right side of the epi curve, finally. And as you see, that curve is going in the right direction. And our peak number of cases were in April, and I'll remind you again, April 9th. Was the date that we implemented the commissioner's order, and then the one that you ratified subsequently. We have seen astronomical increases in vaccination from April 9th, when the emergency order was issued, to June 9th, 2019. There have been 51,124 MMR vaccines given in New York City. Of those, almost 4,000 are in Williamsburg, and this is in children aged 6 months to 18 years of age. This is an additional 14,130 vaccinations as compared to the same time period last year. That's a 38% increase citywide. Footnote, Williamsburg went from 1928 to 3,844. That is a 99% increase in Williamsburg, which is the target of the commissioner's order and the emergency response. In terms of what we've done to date, really focusing on our enforcement actions, commissioner's orders were issued to 104 schools and childcare facilities in Williamsburg to exclude unvaccinated students for face violations and possible closure. We have issued 35 programs notices of violations. 4 schools and 5 childcare facilities have been ordered to close, and all of these facilities have reopened to date. Individual summonses for mainly children who have not been vaccinated have also been issued to 173 individuals. Thankfully, 68 of them have been canceled, and the majority because of vaccination. So we're going in the right direction. Additionally, many recent outreach efforts have occurred. We continue to engage both providers and the community in our outreach, including a phone bank on measles that happened with Univision. We've distributed Spanish language FAQs on the measles outbreak to our community partners. We've attended community health fairs and hosted informational forums. Additionally, we've mailed to households in Williamsburg and Borough Park 29,000 copies of a wonderful document that I will show you the cover of shortly, called A Slice of Pie. And it's a detailed response to Peach, which is an organization that is staunchly anti-vax that has gone into Williamsburg and spread a lot of misinformation. The slice of pie actually focuses on providing evidence-based and detailed information about the safety and efficacy of vaccines, including the MMR. We've also done a lot of work in publishing print ads in English, Yiddish, Spanish, and Chinese. So this is Slice of Pie. It's available on our website. It was actually created in collaboration with the Vaccine Task Force and really goes through the fundamentals of vaccines, focusing on some of the truths to oppose some of the mistruths that have been spread by the anti-vax campaign throughout the country and now unfortunately focused in New York. Additionally, these are examples of some of the campaign that we put up. So this one is currently all over Williamsburg and Borough Park. You can see that it's in English as well as in Yiddish, and it really focuses on the importance of a vaccine, not only on the individual perspective, but also from the community perspective, and the importance of, in effect, herd immunity in preventing transmission, especially to individuals who may be more susceptible. There are other signs that you may have seen in clinical settings and potentially at airports to remind people about the importance of vaccination, as well as the fact that there currently is a measles outbreak occurring in our jurisdiction. And not yet, but coming out very soon, is a campaign that focuses really on the anti-vax rhetoric, reminding people that really measles vaccines are safe, effective, and that there's no link with many of the diseases, including autism, that anti-vaxxers will often cite as a reason not to get the MMR and instead to get measles, which we think is a bad idea. Thank you.
Thank you, Dr. Daskalakis. There's just two things I want to emphasize. One is I want to give my thanks again to the team and Dr. Daskalakis for his leadership in this activation. We have over 400 staff members throughout the department that have been working day and night to bring this outbreak to an end, and I think you can agree by what we're seeing on the epi curve that we are cautiously optimistic that we are on the right side of the epi curve. The other thing is, I think it's indicative of the ingenuity and the creativeness of staff that we're able to come up with a graphic to convey the concept of herd immunity. That's not something that had been in the sort of national discourse, and now, you know, we're hearing about herd immunity all over the place, and lay people are really understanding the importance of that concept. So again, I want to thank the team and open up for any questions there might be.
I'm just going to also quickly say thank you to Dr. Barbeau, because my leadership would not be possible without her leadership. So thank you very much.
It's seemingly a minor side point. Why
Just
I
hold
can't
it down.
hold it down.
I'll hold it down.
No, I can hold it down. I got it. And that is just to, because I believe that the mathematics will sort of bear me out here, that there's really a distinction to be made between the Orthodox and the Hasidic community. I think one group is more susceptible to vax than the other. One group is more vulnerable probably to the anti-vax conversations. But and I'm sure in your outreach you deal with that, but I just wanted to highlight that distinction because they're really two different groups.
Thank you. I think we definitely have made our outreach very specifically focus on the anti-vax rhetoric, because they're pervasive in more than just the Jewish community, and so we want to make sure that we are dispelling their myths for all communities.
Otherwise, I have to say, this is New York City Health Department at its most brilliant and best, and it's really very gratifying and very pleasing to see.
Thank you.
Here, here.
Thank you. Dr. Foreman?
Yeah, actually, thank you. I think this is very impressive. I'm sort of thinking of Paul Offit, who's a leader in combating this, would be very proud of a public health department going tete-a-tete with the anti-vaxxers. And that slide that said spread, if you go back one, I really love that. Spread the truth, not measles. I cannot wait to see that across all the subways and buses.
Yes.
That's really like not shying away from really going up at it. And so I'm very impressed.
Just to sort of follow up on that, Paul Uppett actually gave us a direct shout out in the New York Times, so he was very pleased.
I missed that.
Any other questions? Yes, Dr. Klitschko.
Yeah, I too am very impressed and heartened by this effort, although I am deeply troubled that this is what we're doing in 2019. But with that being said, do you have any estimate of what the percentage or number of children in Williamsburg and Borough Park and other communities that have either not been vaccinated at all or under-vaccinated still?
So we're thankfully, because of our city immunization registry, we're able to work on calculating that. The good news is I can't give you a number because it's a moving target because it gets smaller and smaller. So because of the explosive increase in vaccination, especially in that 6-month to 11-month range, and also and above, like we really think that the population is shrinking, and we're currently working on an estimate. I forgot to give one really interesting number, which is around the vaccination of the 6 to 11 months old, which is like a vaccination requirement that is really based on the outbreak. It's not a routine recommendation. So I think that an 8,367% increase from last year demonstrates that the word has gotten out to that population to get vaccinated. And we really, again, it's a very small group of individuals in this community who are still susceptible to anti-vax recommendations because really it has exploded with a response with individuals getting vaccine, especially in Williamsburg.
Great, thank you. Hearing no other questions, we will adjourn the meeting. Thank you all very much.
Thank you.